Hello and welcome to the Birth Untethered podcast. I'm Shellie, a long-time doula, advocate and former university lecturer.
And I'm Kemi, a badass birth keeper, formerly a UK registered midwife.
Just a couple of rebels with decades of combined experience in pregnancy, birth and beyond getting together to share wisdom. We exist to equip birth workers, families and seekers of truth with informed choice, not fear. Come as you are, learn what they don't teach. This is the birth revolution and you're all invited. Hello everybody.
Can't take nothing serious.
I just started serenading Kemi before we started recording.
Yeah.
Are you ready? And she's ready. She's ready for love.
Oh yeah.
Welcome everybody to season 2, episode 4. And in the last episode, we just about made our way through the booking appointment and the first ultrasound scan before we got sidetracked. And we left off with the promise of speaking a little at the beginning of this episode about screening for PAPP-A. What is it? Why you may or may not want to consent to testing for this. I'm going to say here that you need to be explicitly clear about what you do and do not consent to, and ensure that the person understands and has repeated back to you their understanding of what you do and do not consent to. And if you don't trust them, that you are clear that you understand that anything they do without your explicit consent will be considered assault. Okay, and I'm saying that just because I've seen assault happen way too many times. People consent to a vaginal examination, they end up with an unconsented sweep. People consent to a urine test and they end up with a GBS test that they didn't ask for. You know, these things that they might just automatically do without thinking, and they don't really understand consent, even though it's kind of ingrained in the framework of things that people should be gaining informed consent. There's not really an understanding of what that is. And I think what's taught is like escalating coercion to gain compliance rather than giving information and then not minding what the person decides. That's not how consent works in the NHS for the vast majority of people that you are coming across. Okay, where you and I may think of consent as, here are the upsides, here are the downsides that we know of. There may be others that we don't actually know of yet. If you choose this path, it may lead to this, this and this, which you may or may not want. If you choose this path, it could lead to this, this and this, which you may or may not want. Do you require any further information to make your decision? Do you want to make your decision now, or do you want to wait a little while? It's up to you. I will respect whatever you decide, even if I think that that choice of that path is not the right one. Yeah, because it's not my journey. That's how informed consent should be. But
What we should do,
actually is.
We should record that, yeah, and then we send it to all the trusts. I think that name's hilarious. We send it out to all the trusts, right? And then they just play. They just press play, like at the beginning of the appointment. Then you say what consent actually is, and then we continue. That's seriously what should happen, because the law's getting broken thousands of times a day, every fucking day.
It really is. I mean, I was with a client recently who said that she wanted to know before any medications were administered to her in theatre. She wanted to know what they were for, so that she could decide if she wanted that or not.
Sounds fair.
Literally, someone in the theatre went, "Why would you want to refuse medication?"
Perplexed.
I was like, that's informed consent. You know, the person gets to decide if they want to have opiates or not. You know, if they want to have blood thinners or not. You know, they want to have whatever it is or not. It's, you know, so yeah. People
but that registrant was perplexed. Registrant means conducted several years of study, assessed at various points, finally assessed, put on a register.
Yeah, they were obviously an experienced member of theatre staff. I'll say they moved around that room like they really knew what they were doing. Didn't know about informed consent, apparently. No. So, Yeah, just be mindful of that. And, you know, you can tell people, like, you can record your appointments and you can tell people that you're recording them, and it really helps to cut down coercion. But it also means that you have something to listen back to if you're unsure about anything after the appointment. And we know from studies that people don't take in the vast majority of information that they're given in an appointment. So if that information feels important to you and you'd like to have a chance to revisit it, you absolutely can record appointments. You don't need permission, so you don't actually have to tell the person that you're recording if you don't want to, as long as you're not then sharing it publicly. It's fine for your own use. But actually I think it helps to say, I'm just going to record this appointment just so I've got, you know, I can go back to it if I've missed anything, or just so I know, because it actually helps to cut down the coercion, because when people realise they're being recorded, they might
not
take a
want to
second
break
think.
the law.
Yeah, I mean, hey, this last few weeks they've been breaking the law in black and white and having no qualms about it, so who knows, who knows. Yeah, mad. Okay, so that's our first rant of the day.
Thought we'd get them in early.
Yeah, let's go on to the next one, because Kemi promised a rant if we started talking about PAPP-A last time, didn't you?
said
You did, you warned us, so I'm ready. So what is PAPP-A? What is it? It's pregnancy associated plasma protein A, and it's a placental glycoprotein produced by the placenta in early pregnancy, and basically it plays a role in regulating something called insulin-like growth factor availability by cleaving, so cutting IGF binding proteins, which basically supports placental development and fetal growth. Okay, and it's routinely measured as part of that first trimester combined screening that we spoke about last time, with the ultrasound and the blood tests and the questions about your age and things. Okay, so it's part of that test to determine about those trisomy likelihoods in your pregnancy. Now, a PAPP-A screening result is expressed as multiples of the median, or MOM, which is adjusted for gestational age, so depending on the gestational age. So low PAPP-A, which is usually sort of categorised as below 0.4 MOMs, or below the 5th and 10th, between the 5th and 10th percentile, so below that range. So that's in the scale of people, you know, of 100 people, 5 will be below that level, if that makes sense. And it's associated with a range of placental and pregnancy outcomes.
Associated.
I love the way we both did exactly the same thing. Only yours was more slow and pointed.
Oh man, I already feel weak. I feel weak.
So it's even more loose than a lot of the high-risk labels that obstetricians like to currently stick on people without causing any benefit whatsoever. Okay, and the rationale behind linking low PAPP-A with adverse outcomes is that it may be a part of placental dysfunction. It may sometimes highlight placental dysfunction, because with the lower PAPP-A it suggests the reduced bioavailability of the IGF and potentially this inadequate, this is a very fancy words people, trophoblastic invasion, which may impair placental vascularization and nutrient transfer.
Come on.
Okay, which are mechanisms that are implicated in fetal growth restriction and other disorders of the placenta. Okay, what do all of those big words mean? Basically, the placenta invades into the uterine maternal tissue in order to transfer nutrients and waste products across that placental bed. And if the placenta doesn't implant well, it can't do such a good job of nourishing your baby, so their growth can be restricted. And you can get adaptations later in pregnancy where the demands of the fetus are higher, such as increasing blood pressure, which really, I think, is the body trying to get more blood to the baby so that they are well. But obviously, having a higher blood pressure, not so great for the body, especially when it starts to affect organ function, kidney function, and we get into the realms of preeclampsia and then potentially eclampsia. So associations people are fetal growth restriction, small for gestational age, and low PAPP-A is associated with higher risk of fetal growth restriction and small for gestational age outcomes likely to do with that placental efficiency. But we all know by now that we need to take a dive into what high risk actually means, because in obstetrics, if it means they can intervene more, you're at high risk of things, even when it means that you've got less than a 0.1% chance of anything bad happening, i.e. 99.9% chance that it won't happen and everything will be absolutely fine. So most people with low PAPP-A are healthy and have normal outcomes. Okay, adverse outcomes with low PAPP-A are rare. In one large nulliparous cohort study into PAPP-A, measurement of that low level of less than 0.4, out of 100 people who developed preeclampsia, 90% of them did not have low PAPP-A. So it is a very poor screening test for preeclampsia. Out of every 100 babies who were small for gestational age, about 18 of them were born to people with low PAPP-A. So 82% of small gestational age babies were born to people with normal PAPP-A levels. So it misses the vast majority of growth restricted babies. It is not reliable for predicting risk or ruling it out either. Out of every 100 pregnancies that sadly ended in fetal death, around 21 of those would have low PAPP-A. So 79% of fetal deaths occur in pregnancies without low PAPP-A. So it is not a strong indicator or predictor of stillbirth. Okay, and of course that is one of the most emotionally loaded risk discussions that happen. One of the most misused in order to coerce compliance for medical procedures. And this is something I've noticed with clients that I've had with low PAPP-A. It's like, we want to monitor you more. You have to have an induction. You have to be monitored. Da 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 da. Guess what all my clients with low PAPP-A have done? Had a normal pregnancy, had their babies at home. Everybody's been fine.
Yeah.
Okay, so most people with low PAPP-A will have normal pregnancies. Most adverse outcomes happen in people who don't have low PAPP-A. Its positive predictive value is low. Okay. If it is discovered, however, you will be coerced into extra surveillance, restrictions and pressure for unnecessary intervention. So think very carefully if you want that label or not. Is it going to serve you? Do you want to know? Okay, you'll likely be put on a consultant-led care pathway, which obviously increases the likelihood of serial scans. They may withdraw the offer of home birth or birth centre options with no evidence to do so, and even though they shouldn't. Early induction is often recommended, despite there being absolutely no evidence that intervening solely on PAPP-A, low PAPP-A measurement improves outcomes. It doesn't make things safer or better for you or your baby. There is no proof that intervention pathway improves outcomes, but we do know that it leads to loss of choice, increased induction pressure, heightened anxiety, and the old favourite of obstetrics, framing pregnancy in women as dangerous.
Mm.
Yeah, that risk amplification, not evidence-based care. Okay, so the other chance with low PAPP-A is preterm birth. So in high income countries like the UK, Australia, Europe, the overall preterm birth rates are around the same. Now, what medics would probably tell you is low PAPP-A is associated with a 2 to 5 times higher chance of preterm birth, you know, which can sound really scary.
Oh, that old relative risk ruse.
And we know that they love to do that. Okay. Okay.
I don't even need to rant. I actually don't need. I'm just limp. I'm literally limp with rage. I'm limp with rage.
Basically, any form of preterm birth, okay, so before 36 weeks, you're going to have it in people with a normal PAPP-A level in around 5 to 8% of the population. So 5 to 8 in 100 people. Yeah, so what's that? 95 to 92% will not have preterm birth. And in low PAPP-A, it's around 10 to 20. So that means that 80 to 90% of people with low PAPP-A will still give birth at term and not before. Okay, and if you're getting earlier preterm, so before 34 weeks, the numbers are lower. So it's only 1 to 2% of the population with normal PAPP-A levels and 3 to 6 with low PAPP-A. So that still means that 94 to 97% of people are not going to have a baby before 34 weeks. And with preterm birth, there's actually not a huge amount, so that can be sort of done outside of things to prevent it. Having a doula prevents it, isn't it? A lot of studies have shown that having a doula and continuity of midwifery care reduces that. I think that's like keeping overall general health and stress levels low and stuff like that. So again, the baseline risk for preterm birth is very low. So low PAPP-A increases the relative risk, but most pregnancies, including low PAPP-A, will just continue to term and not be a problem. In terms of the clinical pathways and management, there is no formal screening programme that should use PAPP-A alone to trigger interventions like induction. Does that stop obstetricians doing it?
Oh, no.
Okay, but it's important to know that NICE and the RCOG guidance do not recommend first trimester PAPP-A for routine screening of FGR outside of its role in the combined screening test. But as we said, what often happens clinically is that you get increased surveillance, more serial ultrasounds, looking at fetal growth over time, monitoring for SGA, FGR. Some places will check uterine Doppler, artery Doppler, some won't. Some will increase checking your blood pressure and your protein in your urine more, some won't. So it's not a global thing. Some places will offer aspirin prophylaxis, low dose aspirin, from 12 to 16 weeks.
Don't.
Okay, which shouldn't be offered.
You're poking the bear now. Stop it! Don't get me started.
People have got to know what's going to be offered.
Where's the evidence for offering low dose aspirin for low PAPP-A?
There is none.
Oh wait. Oh, sorry. There is none. Right.
Yeah, not that I can find. And it shouldn't be unless there are other risk factors for placental disorders or preeclampsia existing. Okay? It's stemming from...
Can we move on? I think we've said enough about low PAPP-A because I can't. So shall we move to the next thing?
Okay. It shouldn't lead to an induction pathway. Okay? On its own, it shouldn't basically do anything. Ooh! It's a fire.
Oh, it's all right. Just testing the alarm.
You bring in the fire. To bring in the rage.
It's all right. I'm holding it well, I think.
Okay, so PAPP-A shouldn't change anything, basically, really, on its own. It shouldn't change your birth options.
Noted.
Just, it's there. You don't really need to worry about it. You shouldn't worry about it. Don't let them coerce you because it's not okay. Is that enough? You done with PAPP-A?
Okay, let me just try and be helpful. You will usually find that if you indulge in preconception care, like looking at your diet, maybe checking your levels, etc., you will, and it needs to be for the person you're making a baby with too, because both of you go into the formation of the blastocyst and embryo, placenta, etc. If you pay some close attention to what you're eating and your levels of vitamin, minerals, etc. before birth, you will probably find that even if it is noticed that you have low PAPP-A, you will reduce the chances of preterm birth, growth restriction, stillbirth and toxemia stroke preeclampsia, just from your own actions rather than skipping along, hoping for the best of your fingers crossed, outsourcing, listening to stupid advice from obstetrics about your low PAPP-A, etc. Actually be proactive with your own health and continue that in your pregnancy also. And you'll probably find that you will lower the incidence of placental or placenta-related issues.
Yeah. I mean, there's things out there that show that it does reduce things. Looking at your protein intake is a really important one. Vitamins and minerals, Real Food for Pregnancy by Lily Nichols. Is it Dr. Lily
Love
Nichols? I'm assuming
her.
she's a doctor. I'm
Oh,
assuming she's a
she's
doctor of
so
many things.
anal. I absolutely
Brainy,
love her. Yeah, she's very, very
brainiac.
intelligent.
Yeah. So basically, if you find you have it, actually the likelihood is that everything is going to be fine. If you want to improve your outcomes, the things that are on offer on the NHS aren't shown to do that, but you can do things yourself at home by improving your diet, keeping yourself healthy. That can. So come untethered from the fear, come into the using your own amazing brain and body to work as best it can. Okay, let's carry on with...
Okay, one more wonderful thing, because I love solutions. I love
This
solutions.
is going to turn into a three-part episode.
Three-parter. I know. Sorry, we've actually got work to do as well after this, haven't we? Having a laugh with our mates in a podcast. Get chubby with a naturopath, please. Shelley's one. Get chummy with a naturopath. I will be becoming one because it's just too interesting. But there's so much you can do with a naturopath pre-conception and get advice from during pregnancy as well. That's actually the route you need to be going down rather than buying shit on Temu and all that crap that y'all are doing out there in preparation for growing families. Could you instead get to know a naturopath and work with them? And then you will be giving you and your baby the best chance of an amazing birth without having your options stripped away or having to go to a hospital every 5 minutes or some other kind of screening or scanning or investigation. Why not just invest in your health? Because you're growing a whole human inside of you. Of course, the only thing they're going to have access to is what you've got. So you've got to be healthy to be able to produce a healthy baby. And that includes your microbiome as well. If you've got a crappy microbiome, your baby will inherit from you a crappy microbiome. So look at, what your vaginal flora is like, your gut flora, etc. Improve it. Why not?
Yeah, okay. I actually really love that that's becoming more commonplace now. There's a lot more at-home testing things, you can keep an eye on things a lot more easily than you used to be able to, which I think is really brilliant. Like, just take control of your own health. And the thing is, standard medical people have no idea about diet. No. They don't learn about nutrition. They don't know about vitamin deficiency. I mean, I had a patient, she very clearly had vitamin D deficiency. To me, she was demonstrating all the symptoms and, had been keeping out of the sun because she was frightened of getting a melanoma because she'd had one previously. And I said, you need to go, I think that you were really low. You need to supplement vitamin D. She's like, I don't really want to take things without testing. I was like, well, I'll write a letter to your GP. And the GP said, I'll eat my hat if you've got low vitamin D. Well, she had severely low. And bless her, she actually went back to the GP and said, well, you better eat your hat. you better write an apology.
And watch you eat it.
Yeah, write an apology to my osteopath because she was right and you were wrong, which I thought was brilliant. So it's take control of your own health. Look at things. What am I missing? What do I need more of? What do I need to change to make me healthy? And sometimes when it feels difficult to motivate yourself to be healthy just for yourself, which I can understand can be hard, that when you're pregnant you have that added motivation of making a baby healthy, or you're planning to get pregnant, you have that added motivation of making sure that your body is as healthy as it can be, is a great vessel for growing and birthing your baby, and that can be really useful for making positive lifestyle changes that will benefit you and your baby and your babies, grandbabies down the line,
grandbabies down the line
forever. So do things. Or you could hand yourself over to the NHS and go up to your 16-week appointment.
Fuck no.
where they're going to review and discuss results from your earlier screening, offer you blood pressure and urine tests, and check on any well-being or concerns that you have. And they may say to you, oh, from your blood tests, it looks like really you should consider some iron supplements. Guess what? The NHS iron supplements are shit. And they give you trouble with your shit. Ferrous sulfate is literally the cheapest crap that they can give you to get iron into your body. It does it really badly. A lot of people cannot absorb it well. It makes a lot of people feel constipated and awful and gives them hard black poos.
Thank you. Whilst you're pregnant.
No, thank you. So, you know...
So if anyone gives you ferrous sulfate, they hate you and your kids. Okay? They do. We all know, all of us that are registering, so I'm obviously beyond registration now, otherwise I could not talk like this. I literally had to give it up so I could tell you all the truth, right? Without getting harassed, stalked, okay? If any registrant knows that ferrous sulfate is the worst shit to give to people.
Do they?
Oh, come on. Otherwise, just give up your registration if you don't know that. That's like class 101. Everyone knows. Everyone knows the sulfate, what the sulfate does, right? So if a registrant puts a packet of those in your hand, they don't care about you or your baby. Don't take it. Seek alternatives. Go on, Shellie, because this is a big one. This is a big one.
Yeah. Is it just have a chat with somebody who understands about nutrition.
Shellie,
have a chat with other parents. You know, just like, don't take ferrous sulfate. It's horrible.
Even Kemi, who's just trained as a midwife, who just registered as a midwife. I knew that. Didn't need to be a naturopath to know that. But yeah, please speak to someone that actually knows. And your common or garden midwife, they do know, but they just don't care.
Oh, okay. Yeah, that makes me sad. I mean, I sort of almost can forgive ignorance, like not knowing, if you're not taught in a bit. I can forgive it a bit up to a point. When they don't know.
How do you forgive it a bit?
Well, I don't know. I try to be a forgiving person so that I'm not just mad all the time. Do you know?
I know.
But
I'm going to go meditate after this session. I knew it was going to be difficult. Go on.
Yeah. Well, it's the the thing is we spoke about the good option at the beginning of removing yourself from all this conveyor belt of nonsense and just looking at things yourself. But some people choose the conveyor belt, and so we got to go through it and. People can see our pain going through it, hopefully recognise that it might be their pain mirrored going through it, and might make a untethered choice, you know, to like just pick and choose what they feel they need. You know, we're offering up our pain for everybody else's learning.
Absolutely. No.
Oh gosh. So don't go with the pain of ferrous sulfate. Perhaps you might choose to go for the pain of the anomaly scan.
Ferrous they offer, which is slightly better.
Yeah, you know, there's so many things that you can take, you know, or eat, you know. Yeah, so anyway, that's for another time. Okay, so around 18 to 21 weeks, you're going to be offered the anomaly scan, which is a detailed assessment of
Do we mean anatomy scan?
Yes, what did I say?
Anomaly.
Oh, well, yeah, they are looking for anomalies, but yes, it is an anatomy scan.
Shall we just call it an anatomy scan? Honestly,
sure.
No. Why are we calling it anomaly scan? Focus on anomaly. Oh, we've got to find an anomaly. Let's find some anomalies. They're just scanning the anatomy of your baby. Shall we just do that? And if an anomaly is there, it'll be seen because they're supposed to be experts. Do you see what I mean? What are we focusing parents' minds on?
Yeah, it's true. It's true. So they're looking at your baby's anatomy. Yeah. And it needs to be at this time because as babies get bigger, it's more difficult to see these things. So that's why it's between 18 to 21 weeks. But just it has very moderate accuracy for detecting structural anomalies.
It's very polite.
Okay, so they systematically are trying to review the anatomy of your baby, including their brain and spine. So they're checking for things like spina bifida, where it's not closing fully. They're looking at the heart for any major or structural defects. They're looking at the kidneys and bladder, the abdominal wall, the limbs. They look at the facial structure, but the capacity of that to really see everything is quite limited. They're looking at the placental position, and they'll probably look at the amniotic fluid volume as well. Okay, so the accuracy of detection of things varies hugely by the condition that they're looking for. So the overall detection of major structural anomalies is around 45 to 60%. Okay, so tossing a coin. About, do you have an anomaly or not? Ding! Okay. For some conditions, it's a bit higher. So for looking for anencephaly, so where there's change in fluid and shape and size and things of the brain, that's more accurate. So over 95% of the time, they will pick that up. Okay. For some of the heart things that they're looking for, again, it's around 50-50. So tossing a coin. A normal scan doesn't mean that everything's normal, and an abnormal finding might be uncertain or not be true later, so it can cause a lot of anxiety. Okay. Now, some people might choose that they want to know about the position of their placenta. Okay, because if you have the placenta sitting over the cervix, that's called a placenta previa, blocking the exit, basically. But you know, at 20 weeks, often placentas look like they're covering the cervix because the uterus hasn't yet grown and stretched, and the placenta, as it stretches, the placenta comes up as the baby gets bigger. So around 5 to 10% of people are told at a 20-week scan that they've got a low-lying placenta covering the cervix. But by the time they get to term, 90 to 95% of those people will not have a placenta covering their cervix. So if you're the kind of person that gets really anxious and thinks, oh, if it's still covering my cervix, I've got to have a cesarean in your mind, do you really need to know at that point? Is it helpful for you? Okay, for some people it may be helpful, some people it may not. But true placenta previa at term occurs in about 0.5% of pregnancies. So 99.5% of people will not have that. Yet all those people are being worried for no reason for all that time.
What used to happen, a couple of decades ago, was placenta previa. It was always a diagnosis that related to, well, up until, no, it's up until a couple of years ago, to be honest, when there's a part of the placenta that's covering the internal os. So that's the opening of the cervix on the inside, because, the cervix is a bit like a cone. So the bit that's contacting the baby, the inner part of the cervix, if that was partially or completely covered, that would be called placenta previa. They've now changed the term to include placentas where the edge is within 2 centimetres of the internal os. They now will call that placenta previa, even though it's not. It is not covering any part of the os, but because it's within that 2 centimetre margin, they will use the term previa with the woman, and then, send her down that hellhole of, oh, I can't have a vaginal birth, and not tell her the statistics that you've just given us. So those of us that work with women in a real way, 2 centimetres isn't sufficient for us to even say, even if it's 2 centimetres at term, we would still say, well, let's just see how it goes. If you've not had an episodic bleeding or whatever, let's just see how it goes. And then we would continue to look after them at home, even if it's like 1.5 centimetres or something. But in the hospital, they would, if it's 2 centimetres or less from the internal os at term, then they will definitely be suggesting a cesarean.
I feel like they didn't used to say anything to people unless it was really completely covering the internal os. And now I think they're saying it to create fear. There's like this real drive to talk to people about problems. And I think it's come from the misunderstanding of the Montgomery Lanarkshire case about giving people information, which what medical people have interpreted as to give people all the scary information to coerce them down the pathway that makes them feel safer as the practitioner, rather than giving information that is helpful and relevant to the woman. Because if 90% of people, by the time they get to term, that's not going to be an issue, why are you scaring them with that issue at that point?
Yeah.
What is the point of that other than to create fear and make people more controllable?
100%.
You could say, at the moment, your placenta is low-lying. 90% of them are going to move out of the way, so we're not going to worry about it.
Yeah.
If you'd like, we can have the
another
vast
look.
majority of people are going to not need anything in the future. But if you'd like us to have another look towards the end, we can. Done.
Yeah.
Nothing to worry about.
Yeah.
But no, that's not how it's framed.
No.
Okay, we need to make plans for a cesarean now. It's just, it's all part of the fear-mongering. And this is the thing. You can get these scans outside of the institution. You can pay privately for a scan where you're less likely to get fear-mongering because their budget is not dependent on creating intervention to create more money.
Exactly.
For the unit, who are desperate for money.
Desperate. Because they misuse so much of it. They're spendthrifts. So they pay, well over the odds, like by a factor of 20 for things that you could just go and buy on the street for way less. But they pay because it's not their money. It's public funds, so they don't give a fuck. Also,
and there's all the middle management, unnecessary middle management.
Yeah, paying for them, just like paying for a bag of fart, isn't it? What people also need to know is, because this is a big waste of money, yeah? Okay. Just anyone want to know why the bag of fart reference had to come in, right? 32 weeks, they will often suggest looking at this situation again. So you could go for a scan at 32 weeks, or you could just hear what Shellie said a few minutes ago about the odds of your placenta not migrating upwards because it's attached to the uterus. The uterus stretches upwards longitudinally, and so naturally wherever it is attached will move upwards longitudinally, right? So you could just hear that from Shellie and go out for brunch instead of going and sitting in a waiting room wringing your hands, right? But actually, them doing that at 32 weeks, yes, it serves a purpose if you believe their shit. It serves a purpose as hopefully...
But why at 32 weeks? Your baby hasn't grown much by 32 weeks. So...
Come on, let me finish a sentence, girl. Right?
Sorry, I was getting ragey.
Get ragey with me.
I'm doing a you. We swapped roles.
She's doing a me, exactly, rather than me interrupting
You're giving the information and I'm getting mad.
32 weeks, they'll say, come back in 32 weeks and have a look. But actually, the lower section part of the uterus, it's like when you're blowing up a balloon, the top of it gets kind of paler and bigger first, and then eventually the air will start to stretch out the part where you're going to tie the knot in the balloon. So the lower section part, that's stretching upwards, really happens from 34 weeks onwards. So whenever people say, they're told we've got to come back at 32 weeks to make a decision, I say actually consider again, if you're buying into this crap, consider again having it at 38 weeks, because then the lower section would have been able to do its stretching as well. So even wherever you find it at 32 weeks, you're going to find it even higher at 38 weeks. That's all I'm saying. If you're still pregnant. And, 89% of women are still pregnant by 40 weeks. So, yeah.
Yeah. And so with regard to the scan, okay, remember, it's your choice. And all of the elements within that scan are your choice. So you can accept or decline whichever part of it you want, including the whole thing. And there is no clear evidence of improved perinatal mortality in low-risk populations with 20-week scan. So there you go. Okay, so it's being done to everyone, and there isn't evidence that improves outcomes. Okay, and there are potential risks, and if you have joined us as an untethered rebel, there are lots of references in the amazing PDFs that I create that don't get the love they deserve. So come and join us as an untethered rebel, is what I'm going to say. Yeah, just give us £10 a month. You can hang out with me and Kemi for a nice chat once a month on Zoom. You get loads of extra information, loads of references, and you support us doing all this hard work to bring you a podcast. So there you go. I've said it. Come and join us. Come and be untethered. Okay, and there's loads of links in there to research about ultrasound and the potential risks and downsides that aren't really spoken about. But I think there's 5 to 10 papers that I've referenced in there that you might want to have a little look at to gain more insight. Okay, so we're moving on. We're just over halfway through now. All these endless appointments. Oh my gosh, I feel like I'm pregnant. I'm going through this horrible slog of appointments. 24 to 28 weeks. You may be offered the oral glucose tolerance tests. So basically they want you to fast, then they'll give you a specific amount of glucose, 75 grams for you nerds that want to know, and then they'll measure your blood at 1 and 2 hours afterwards to check for what's happening in your blood, how is your insulin working, etc. Now we're going to probably speak about this in more detail in another episode, but basically the thresholds to diagnose gestational diabetes were lowered by consensus of this consortium that has a very long name. And actually, if you want to know more detail about it before we record an episode about it, I did an episode with Erin Fung on the Better Birth podcast, which is season 11, episode 5. Okay, so if you really want to know more about gestational diabetes and the testing and the thresholds and the outcomes and how it's actually made it worse, go and listen to that. And in the show notes of that episode, there's a discount code to get my bite-size birth gestational diabetes lecture and handout, which has got loads of naturopathic information for helpful supplements and dietary and lifestyle things that may be interesting if you are concerned that you have an intolerance to carbohydrates, which is what I'm going to call it.
I love it.
Okay, so that lowering threshold did not change key neonatal outcomes for population as a whole. Okay, it didn't make it better for mothers and babies, and actually it has in a lot of ways made it much worse for mothers in terms of medications and side effects of those medications and blood clot deaths and
And babies, because they're not laying down the brown fat.
Exactly. Babies are skinnier and not necessarily in a good way. Okay, so it hasn't really reduced shoulder dystocia. I think one study they found a slight reduction in shoulder dystocia. Probably would have been far greater reduced if they just let women birth in the position they wanted.
Thank you.
There you go. Said it. So there was a high quality systematic review and meta-analysis published in the BMJ in 2016, so it was like 10 years ago now, which found a linear association between glucose levels and adverse outcomes, rather than a clear glucose threshold where risk suddenly appears. So that means if you're slightly over the made-up threshold, it's a made-up threshold. It's not been done by evidence. It's been done by consensus. Consensus by people who probably have investments in metformin and insulin drug companies that mean if they lower the thresholds, they get more money. Okay, just follow the money.
Come on! Just join the dots. Come on!
Okay, so these cut-offs are arbitrary and they are not strongly predictive of most outcomes. Okay. Lower diagnostic thresholds are consistently associated with increased inductions, more antenatal monitoring visits, increased neonatal stay because of care provider fear rather than there actually being a problem, more admissions, more psychological burden, and no clear public health benefit, again, to the testing. Okay, you can measure if you are concerned that you might have issues with carbohydrate tolerance, measure your own levels at home. There are plenty of home testing things now that can help you with your diet and lifestyle. You don't have to tell people if you don't want to. If you can get things under control yourself and in normal levels, okay, there is benefit to that.
Because the levels they've set for mothers are actually lower than the general population. Even they're the ones that need to carry more serum glucose because they're growing a child. So it doesn't take long to join these dots.
Yeah, I mean, I talk about this more in the episode with Erin, but, you know, at this point in your pregnancy, why it's done at this point in your pregnancy is due to changes in the placental hormones. That means that your blood sugar is higher for longer after you eat intentionally so that your baby gets fed, so that your baby grows. And if that doesn't happen, then your baby's going to be smaller. And, you know, we know that medics fear big babies. We've got lots of evidence to show that their fear of big babies is more dangerous than a baby just being the size that they're meant to be.
Yeah, I've got that
Okay.
research. That research has been done. They told my mum to smoke because of fear of big babies. That's what they were doing in the 60s. So why do you trust these people? I don't know why
Oh
you
my
trust
gosh.
these people.
I did not know that. Wow, you learn something new every day.
I don't know why they're called trusts. I think I'm going to start, seeing as everyone's starting campaigns, I'm going to start a campaign.
Untrust.
Do not trust them.
Oh my gosh. Just, yeah, ask questions. And if they don't know the answer, find the answer out yourselves. And quite honestly, I
Please.
wouldn't trust their answers most of the time because they just
Please.
barefaced lie. In my experience, a lot of the time, if they don't know the answer, they're not willing to say, actually, do you know what? I don't know that answer. I'm going to go look it up. If you asked
Come
me or
on.
Kemi a question and we didn't know the answer, we'd be like,
Don't
leave it with
know.
me.
But I will
I'm
look
going
it
on a
up.
deep dive.
Yeah.
Not, I'm just going to make up some
I'll just
statistics
make
that
up
make
some
you do
shit.
what I want.
What about, who was it that said the other day, one of our beautiful peers, that they were told, they were sat with their client who was told that there's a 10% rupture rate after one previous cesarean. 10%!
Was that Carmen?
It might have been our Carmen, yeah.
Yeah, Kemi, Carmen and I and Emma Ashworth actually are all getting together to do Unleash Your VBAC Power in March. So we'll just do a little plug for that.
Yes.
If you are a birth worker supporting people in VBAC, if you are a parent, if you're just interested, come along because there'll be lots of juicy information there about anatomy, physiology, stats around VBACs, biomechanics.
Mindset, the mindset. What Carmen's bringing on mindset is powerful. Your
That's the
nervous
key
system.
bit. And Emma's obviously bringing stuff about rights
Yes.
there. So you've got the entire, like, full holistic package for that. I'll put a link in the show notes to that actually because everyone should do that. It's brilliant. I'm looking forward to it just to listen to you and Carmen and Emma speak again. Never mind my bit.
Oh, you're such
Never mind
a
my
flirt.
biomechanic bit.
You're such a flirt.
Okay, right, come on, we've got to get back on the slog.
Yeah,
Back
go
on the
on.
conveyor belt.
Go
Okay,
on
at
then.
25 weeks you're going to have a little another meeting. Have your blood pressure, urine checked, offered the fundal height measurement. And let's just quickly
That
say
lovely
that Cochrane,
scientific fundal height measurement.
the Cochrane review concluded that there is insufficient high quality evidence to show that routine measurement improves clinically meaningful outcomes compared to abdominal palpation or no measurement at all.
Ooh.
There is no clear outcome benefit for this kind of measurement.
I love it. I love it. Love it.
Okay, and I think we touched on this briefly a little bit before, but basically there's very mixed performance in detecting small or large babies, and the sensitivity and specificity varies widely across studies. Okay, so it's unreliable, not very good at predicting things. It's poor at predicting gestational age with wide error margins of plus or minus 2 weeks compared to ultrasound dating. The sensitivity to detect infants over the 90th centile is around 16.6%.
Wow.
So
that's what? What is that? 83%
80.
chance of error.
They'll get it wrong. Yeah, sensitivity for detecting a baby below the 10th centile is 17.3. So pretty similar.
And they're just spending all the public funds on this shite. And you've got all the sheep lining up in waiting rooms. Yeah, I said it. Come on. Wake the fuck up.
Okay, what is good is the specificity is 92.4 to 95.5, which means that most babies who are not growth restricted won't be falsely flagged. But it does mean that with the low sensitivity that many babies that are small or large will not be detected. And the systematic review also showed that sensitivity ranged from 27 to 76%, and the specificity from 72 to 92. So it's
Look
just
how
very
wide those parameters are.
so unreliable. So unreliable. And even more so if you're not having continuity of care, obviously, because if you've got different people measuring, they're going to do different things and they're not really going to know or understand.
No.
Okay, so with everything, looking at things over time, where you get a serial trend over time of things, may give you an idea of something. It's not a diagnostic test, but it's a screening. It's like screening for further testing. Do you want further testing? If not, why are you doing it? Okay. They'll also probably discuss with you at this appointment your baby's movements and when to seek help regarding your baby's movements. Kemi, would you like to say anything about that? What you would advise?
I'm losing the will to live, to be honest.
Okay, so I would say, I think with babies' movements on the inside reflect their movements on the outside. So if you've got a wriggle bum on the inside, you're going to have a wriggle bum on the outside.
Exactly.
And they tend to have patterns, much like us as people, because they're people, little people, that they're more active at some periods of the day and having a snooze at other periods of the day. So if you can get to kind of recognise what your baby's pattern is like, that can give you an idea of what they're like as a human, and also if there's a cause for concern, if their pattern changes significantly, if they start moving a lot less, or indeed if they are making very vigorous movements, that would be something that could be concerning. You know, I would advise people to go in.
Always.
What I wish is that when they went in, that didn't come with a side order of coercion. I wish that it came with okay, let's really check and make sure everything's all right with your baby to the best of our possible ability.
Yeah.
It's looking like it is, or we're seeing this sign that's a bit concerning. You know, we could offer this, this and this. What do you want to do? But often what it is, oh, you've come in for reduced movement, so, you know, we're going to put you on the induction pathway.
Yeah, exactly. And, you know, Affirm, which was a great trial about movements and what is done about them, in inverted commas, did find that there was no improvement in outcomes from putting people on intervention pathways because of the movements. So the induction obviously comes with its own iatrogenic harm. The caesarean that cascaded from the induction has its iatrogenic harm. And there was no improvement in saving babies who were being investigated because of reduced movements. So the whole thing of the pattern is really true. You know, as a midwife, if you've got a baby that's quiet and then suddenly, you know, literally striking out and moving too much, thrashing around, please go and check. Yeah. And so, yes, you get a side order of fear-mongering and coercion because they're rubbing their hands together, your low-hanging fruit for interventions. But that's where you're going to need to really speak with somebody like me, with Shellie. There's a few of us that offer sessions that give you thinking space, that give you information, true information, so that you can make a decision that's slightly less fear-led. Whilst if you just go to them, listen to their shite and nod along vigorously thinking they're going to save you, Affirm have already shown it doesn't improve outcomes.
Yeah, and I think it's important to say here that if you have a gut feeling that something is not right, that even if you are the kind of sitting on the fence of I'd rather not have intervention, if your gut is telling you something is not right, please go and get checked out. And even if the CTG says your baby is fine, we know that CTG literally just tells you your baby is alive in that moment. It doesn't tell you what's going to happen in the future. No. I know medics like to pretend that it does when it suits them and say that it doesn't when it doesn't suit them. They like to use it both ways to their advantage. But, you know, I have had a few people that have done exactly that, had a call with me, gone to the hospital. In fact, we're going to get some of them onto the podcast to talk about it in this series because, you know, I want people to realise that Kemi and I are not anti-intervention. We are anti-unnecessary intervention. Okay, and we are trying to help you have the tools so that you can recognise when it may be the better choice to have an intervention. Yeah, and like I say, both of us have spoken to people, and the parent might have said, well, they found this, but I'm thinking I'm still going to wait. And we've said, okay, do you know what that actually means? Has it been to explain to you what that actually means? Because that to me sounds probably a bit more concerning than you're feeling it is. You know, I had someone where they were trying to push for an induction, but her baby had clear signs of growth restriction. And I said, it's not recommended in NICE guidance to have an induction in this situation. I don't think it's a good idea, but obviously it's your choice. Do you have enough information from your doctor? You know, the doctor's like, oh no, we don't just do cesareans, you know, we'll do an induction, da da da. I'm like, yeah, but these signs are pretty concerning. And she advocated so hard for a cesarean, had one, and then afterwards the doctor said, I'm really glad that you did advocate very strongly. I'm sorry I was quite rude to you before, but I actually, now I've looked at the placenta and the cord, I think your baby would have gone through a lot of harm had we done
a lot of harm. Died is the word we're looking for, right?
Yeah.
And the thing is, if that had happened, that poor family would have had to go through hell for a year, you know, looking for a negligence lawyer, then start the whole process of trying to get some kind of recompense. And then they'd be told, you know, oh, lessons will be learned, oh, you know, all of this shit. But that baby would have been sacrificed because of outsourcing. So,
and lessons are not learned. I'm just gonna. I just, you know, we've had so many reports.
Sing it, sister.
Just
are the lessons learned?
No.
No. Are we seeing the stats
to
reduce of this harm? Even if the baby doesn't die, that poor baby that's growth restricted, getting pounded out of a woman over a 96-hour period, will most likely have some degree of hypoxic ischemic encephalopathy. Some degree, right?
Yeah.
So then you've got a baby that's living a life that isn't as rich as it could have been if that baby had just been born by cesarean.
Yeah. So yeah, get some advice that you trust.
Yeah.
Okay. That is happy to answer your questions as much as you need. Who doesn't just like look at their watch and say they've got other people to look after. Really, this is very important. This is your life, your baby's life, your whole family's lives are going to be affected by the decisions that you choose to make. So choose wisely. Okay? All right, back on the train. We're at 28 weeks now. We're nearly there. So you'll be given repeat blood tests, full blood count again to check for your iron levels, etc. What looking for worsening anemia, because as pregnancy goes on, your plasma volume expands. So again, you may be offered those delightful ferrous sulfates, people. They might do a repeat antibody screening. So again, they're checking for anti-D, etc. Check if any sensitization has occurred, and offer the anti-D prophylaxis if required. You may be offered GD testing again, which again you can accept or decline, and they will start to offer information about prepping for your labour, also RSV vaccine offers and other vaccine offers. We won't go there today. Baby care and vitamin K discussions. Okay, then we get into the third trimester. Thank goodness for that. 31 weeks. Okay, we've got the usual blood pressure, urine, fundal height, listening to the heartbeat, discussions about moving towards labour. Induction grooming alert. Induction grooming alert. It's happening earlier and earlier. I've had people booking appointments. To be,
yeah, I was going to say, NICE guidance. Lord God, that latest one.
No, I'm sorry, that's the not so nice. That
not
really,
so nice. November 2021, where they're just openly saying this is all consensus, barely any evidence to support, right? They suggest that...
Is there evidence to support blanket induction at 41 weeks?
No, there isn't. It's a consensus. They're all sat there just finding new ways to extract money out of the population, right?
No, and they ignored Hannah Darlin's study, which was out at the time, that showed that induction had long-term implications for babies' brains, for babies...
Just like they ignored Hannah Darlin's warm compress evidence when they were writing the OASI bundles, right? So you've got to understand, because about warm compress is about the only thing that is worth doing at that point, right? So what if the woman's not in the water and she can hold it there herself, which of course it helps her maintain her power, which is the opposite of what maternity units want. So I almost lost my thread. What were we talking about?
Gather the red thread. We're talking
No,
about induction
right.
grooming at the
So
first
yeah, induction grooming
first episode.
in the nice guidance suggested to be discussed at the booking meeting. 10 weeks induction. Yeah. So I think you all know where this is going.
Just know. Okay, it's like each appointment. 34 weeks, we're then getting the same sort of things, checking the blood pressure, fundal height, listening to the heartbeat, maybe palpating the position, though I think less and less palpations happening. People are less and less.
Oh yeah, it's like it's a tenet of midwifery care is palpation. We've got to be able to, and I don't think hold the power in my hands. I actually palpate with mothers. So, they'll say, oh, feel this. Oh, yeah, that's your baby's back. This is your baby's head, etc. How
nice is that? How nice is that? Such a lovely thing to do to help people
her
understand
belly. Why would
where their babies
are. Yeah, exactly. Why would I not want her to know? Why would I
that's
not want her to know?
Not normal practice, is it? It's not normal practice.
But the reason why palpation, they don't care anymore is because all the registrants now just quite happy to just send a woman for a scan. And so they're losing their skills.
Yeah. And so around 34 to 36 weeks, it's really important to understand that your hormones are shifting dramatically at this point to make you incredibly protective of your baby. Your oxytocin is increasing, so it makes you much more likely to have tend and befriend and a fawn response to anybody who is perceived as a threat by your central nervous system. Okay, read outside authority figures that are domineering and pretending they know better than you. Okay, so you'll get more grooming for induction. You're going to get, at 36 weeks, these routine checks again. Remember, they're optional. You can accept or decline anything you want. They may start to discuss your birth preferences and signs of labour. And let's read in at this point the scaremongering about all the unlikely dangers that may occur if you're choosing a home birth, but nothing at all whatsoever. Tumbleweed blowing in the wind about the massive increases in risk if you're choosing a hospital birth. Do you get sat down, if you say, I'm going to birth my baby in an obstetric unit, do you get sat down and told, your risk of this increases by X%, your risk of this increases by X%, your risk of this increases by X%? I think
we need to offer this as a masterclass.
We're going to do that we are in the next episode. We're going to touch on place of birth.
Yes.
Yeah, it should be a masterclass. But if you're choosing a home birth, it'll be like, okay, so we're going to transfer you for all of these incredibly unlikely reasons. I know I had some clients recently who they were like, well, we'd need an emergency transfer if there was a cord prolapse. And they were like, how likely is a cord prolapse? And the midwife said, oh, I don't know. They're like, well, do you have numbers? I mean, what you're telling me about these scary risks that could be risking my life, and I've got to go upside down with my hand up your vagina in an ambulance, and you're telling me all these very emotive, like frightening things, but I want to know how likely is that to happen? I don't know. Well, why are you talking about it then? I'm gonna look it up now. And I think they looked it up. I can't remember what the number is. I'll have to look it up.
I can't remember. It's never happened.
100,000 or 10,000 or something like that.
It's really low.
Something really.
I've never seen it happen.
Why are you talking about that? Because you're trying to scare women into birthing in the hospital. It's manipulation. Yeah. It's not for the good of you. It's just, it's not okay. Anyway, so, bleh. Okay, then we get to finally, we're at 40 weeks. Okay, still no baby, because most people haven't had their babies at 40 weeks.
Thank you.
Most babies don't come on their due date, so don't think it's the date that your baby's coming out, because if you do, you're going to be disappointed. Only 4% of babies come on their due date. Okay, the vast majority will come later. Okay,
that's as good as
you'll be offered. Yeah, exactly. You're going to be offered all the same things again, all of which you can accept or decline. You're probably going to get a discussion of the risks of prolonged pregnancy, making it sound really scary, even though it's actually not. If you are healthy and well and you don't have risk factors, you don't have, even if you have made up risk factors, let's just say that, because a lot of them are just made up nonsense, like your age, or your BMI, or whatever other, you've got gestational diabetes that's well controlled. I mean, just any old, the day of the week has a Y in it.
Whether you've had a
So this,
pedicure.
just seriously. Okay. It's described as expectation setting. Expectation. Grooming you for fingering, unnecessary fingering.
Oh man, fisting, everything. Yeah.
Discussions of sweeps. Let me give you a sweep. And this happened from 39 weeks. Yeah. I think I've read in a nice guidance recently when I was researching something, from 39 weeks offer sweeps, which are a form of induction, people. Okay, we'll be talking about it in a separate episode. Just say no. Your body knows what it's doing. It doesn't need no fingers up there rummaging around, traumatizing your cervix. The cervix is, highly innervated tissue. It's highly sensitive. Its job is to hold your baby in and keep them safe until your baby is ready and your body is ready. Go back to our first episodes of season 1, okay, to understand about some of the amazing things happen. Somebody forcing it to become exaggeratedly inflamed is not helpful. It's not helpful for you or your baby. It's just a train to lots of harm and pain and
well, that's what their Cochrane review of sweep said. It just concluded, part of the conclusion was, you still get the same shitload of cascades that you would with any other type of induction.
Yeah. Only you feel worse about it because you've had less sleep, because you've had discordant contractions, because somebody's irritated your cervix so much that your uterus is going, what's going on? And your baby's gone, whoa, what was that? And gone into a funky position. And so then your labour doesn't start. It just, it doesn't get going properly. Anyway, just say no. No, do what you want.
Do what you want, but it's an insult. Do what you want. It's an insult to the whole process of sperm meeting egg and forming a whole human of eyelashes, a butthole and everything, if you think it all comes down to some stranger who's not even bought you dinner forcing their hand inside of your vagina and irritating your cervix. Please. It's far more holy, sacred, complex than that. Stop it.
Yeah. And remember that all of these appointments are optional. Okay, like we said in the last episode about Annabelle, she went to her 40-week appointment and then was like, I will not be having an appointment until I'm 42 weeks. Okay, so she cut out all of the intervening nonsense that will happen in the middle, where you're going to get discussions of labour interventions, membrane sweeps, induction, blah, 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 risks, benefits.
Unsolicited
blah, blah, blah.
phone calls, all the rest of it,
Just,
behave.
You just don't need it. You need to chill out and then be enjoying yourself.
Unsolicited doorstepping. Some people get a visit if they don't answer their phone. They're out of control.
Yeah, they just like to think of you as a naughty child that's not doing what you're told. But the thing is, you get to tell people what you want, and if you hold firm boundaries from the beginning, they tend to do less of this nonsense. And you can say things like, if you continue to call me, I will consider it harassment. Please document in my notes, I have declined this, I have made an informed choice. End it so that it doesn't continue, if you feel able to. If not, get yourself an advocate that can. Okay, beyond 42 weeks you would be offered more intensive monitoring, and that really varies from place to place. Okay, the Birthing Instincts podcast did a good episode. I'll put in the show notes what number it was about kind of non-stress testing and things, and how that really has been shown that if you have a good, everything looks good, it probably is protective for a week. So you don't need to be going in every day. Okay, and I know some people want to go in every day to listen, but if they're just listening in with a CTG, all they're hearing is that your baby's heart is beating at that moment. Okay, and if that listening into that heartbeat comes with an unwanted side helping of coercion to induce to have a sweep and is stressing you out, it will delay the start of your labour because you're going to be stressed.
And Kirsten Small, she's very good on this whole antenatal CTG and the impact on it. She's got blogs out containing links to studies that show that there's an increase in poor outcomes for people that have CTGs. before
Yeah.
labour and birth. And obviously, we already know that CTG during labour and birth does not improve outcomes either. But what Shellie just mentioned is very important, because I'm aware of people that are being forced to go, and I say forced because they're being deceived into going in for daily monitoring. And in the NICE guidance, it still says, and it's guidance, it still says at least twice weekly monitoring. That's what it says. That's what the recommendation is. We've got women being told at 40 weeks that they need to come in every day, and they believe it. And so they're going in every day and being told their baby's going to die every day. What do you think happens, Shellie? What do you think happens?
Well, they get worn down and they give in.
That's the word. They're just worn down and they give in.
They're coerced into something that they didn't actually want in the first place under a false premise that wasn't true. It's totally unethical. And yeah, you know, I said about the NICE guidance, what's here in I've just seen now. NICE guidance specifies offer a sweep from 39 weeks in low risk women after a conversation of the risk and benefits.
39 weeks, so low risk women.
By 41 weeks, sweep and induction discussion are standard components of routine planning for overdue pregnancy. It's not overdue until you pass 42 weeks. And let's remember that it's a guess that could be out by 7 to 10 days anyway. Okay. So,
have you finished yet? Because I can't.
Nearly. We're wrapping up. Okay, we've got to the end. We've had our babies. We've realised after this first birth that next time we're going to step off the conveyor belt of nonsense. Get a blood pressure monitor.
Even talking about it. Thank you, some pea sticks, and if you insist, a tape measure. You know, I asked when I was training as a midwife, I was that annoying person in the class that would question everything.
You?
So so I was so hated by some of my classmates. Fucking hell! Like, we want to leave the lecture and go home. Like, and I said, why? I said, as we only moved to decimal in the 70s, so we were taught both ways, right? But we were taught to more lean into the tape measure. So we were taught about palpation and poles, you know, on the uterus, like belly button, what that means, if you can feel the uterus there, if you can feel the uterus between the belly button and the sternum and all the rest of it. So we taught the old way, and obviously my mentors continued keeping me in the loop of that. But then they said, no, now we've got a better way. We've got the tape measure. And if we measure and it's, say we come up with 32 centimetres, that baby should be 32 weeks pregnancy, or 34 or 30, because there was wiggle room of like 2 centimetres. So I said, I put my hand up, I just sort of heard all the sighs and the tuts. I said, but what happened?
Here we go again.
But I said, why is it suddenly accurate, you know, from when we decimalised in the 70s? Why is it suddenly accurate now? Don't be silly. Of course it's not. And there was like, silence and tuts and everything, and the lecturer had no answer, and there was a bit of an eye roll, etc. But this is why I'm saying to you guys, please stop being so gullible. That's all I'm saying. Yeah, I mean, obviously, Shellie mentioned about 30 minutes ago how it's all been basically debunked about the accuracy of fundal height measurement. But seriously, guys, come on.
Yeah. I think the important thing really is that information isn't inherently empowering. Okay, just think on that. But relevant information is. Yeah, routine care is designed for populations. Okay, but decisions should be led by individuals. So you are allowed to do whatever you want. You can choose less, you can choose more, you can choose differently at different times, and you do not have to justify your decisions to anybody. Okay? There isn't an optimal number and timing of appointments. Routine third trimester ultrasound in low risk pregnancies makes outcomes worse, not better. Surveillance for suspected large babies makes outcomes worse, not better. Many of the aspects are risk profiling and not actually diagnostic. Okay, and most of it persists because it's tradition, because of defensive practice, because of just the institutional chug of momentum going on. So really, when we ask, is antenatal care evidence-based? A lot of it is. So it's better to think, which parts of this care serve me? Serve me physically, serve me emotionally, serve me intuitively, and which don't. So you can accept what feels good, you can decline what doesn't, you can change your mind, you can ask for time, you can ask for evidence or more information, and you can lean into your intuition. Yeah? You are allowed. Allow yourself to become untethered from fear. Okay? Doesn't mean that you have to ignore information. It means that you can integrate evidence, lived experience, inner knowing, and choose from a grounded place of autonomy. You'll feel a lot better if you do. Yeah, you really will. Rather than feeling out of control and like you're doing things just because you've been told and you don't really want to do it, you don't really want to go to appointments, just seize that autonomy for yourself. You will feel so much better if you do. And next time we're going to be talking, well, actually we might do, I don't know what we're going to talk about next time. I'm not even going to say, because Kemi had an idea that we might stick another episode in. I had a plan that we were going to be talking about the next intervention, which is leaving your home, and what evidence actually says about birthplace.
I think we need to do that. I think we need to go there.
But we might have another bonus episode in the middle, or we might have a bonus episode after. Who knows?
Oh, who knows?
We like to wing it here.
It's all untethered.
Untethered, unkempt. Unhinged. That's how it is. Okay, everybody, we will see you next time. I have to go and help a mama now. It's me that's running off on a call.
Yeah.
Bye, everybody. See you next time.
You can sign up to the Birth Untethered mailing list from the link in the show notes. Become an Untethered Rebel, support the show, and join the growing community that meet together online each month to share collective wisdom, support one another, and also to receive extra resources that supplement podcast episodes.
The information shared in this podcast is for educational and informational purposes only and should not be construed as medical advice. The views and opinions expressed by guests are their own and may not reflect those of the hosts. This content does not replace professional medical guidance.